Welcome to our session on the key components of complexity-based evaluation and management. This session will focus on history, which is one of three key components used to meet a complexity-based service. You will want to make sure to review the other sessions for exam and medical decision-making, which are the other two key components for reporting a complexity-based E&M code. My name is Stacy Olson, and I am a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. CPT is the code set that is used to report professional medical services. Evaluation and management codes are included in CPT, but are a small portion of the CPT code set. CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change. It is always the provider's responsibility to know the state and federal rules and to remain current on payer policies. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in what services they may perform and/or bill, but rather is meant to inform you of general knowledge and best practices for billing medical services. Our objectives for this session will be to define the four elements of history as outlined by CMS documentation guidelines and CPT. We will calculate the level of history in a case study using the auditing tool provided by WSPA, and we will illustrate the E&M CPT codes that would be supported for the history level obtained. History can be correlated to the subjective portion of a provider's progress note. History is comprised of four separate elements: the chief complaint, the history of present illness, also known as HPI, the review of systems, or ROS, and the past medical family social history, which is referred to as PFISH. Depending on how much information the provider chooses to obtain and document in each of these elements will determine the overall level of history for the encounter. There are four levels of history, and the amount of elements required vary for each level. Every E&M code, regardless of the setting in which the patient is seen, must have a chief complaint. The HPI, ROS, and PFISH requirements are higher for detailed and comprehensive histories than they are for problem-focused or expanded problem-focused histories. For patients with more complex conditions, or for patients that have not been seen before, it is often medically necessary to obtain a more extensive history. The chief complaint is a concise statement describing the reason the patient is being seen that day and should be stated in the patient's own words. CMS states that only the review of systems and the past medical family social history may be obtained by ancillary staff, so the provider should clearly document the chief complaint in their note. Often the chief complaint is intertwined with the provider's documentation of the history of present illness, which is also fine. If a provider simply states that the patient is being seen for follow-up, this term alone does not suffice for a chief complaint. However, if elaborated upon, it would meet the criteria for a chief complaint. For instance, follow-up for hypertension and diabetes would be fine, as it clearly states what the patient is being seen for that day. The history of present illness is information obtained from the patient regarding their current condition. It should provide a chronological description about the patient's presenting problems. It describes the first sign or symptom of the patient's condition from onset, or a description of the problem from the previous encounter to the present encounter. Per Noridian, which is the Medicare contractor for Washington State, the history of present illness must be obtained and documented by the billing provider during the encounter. Review and acknowledgement of HPI obtained by ancillary staff is not sufficient to receive credit for history of present illness. There are 8 elements that may be credited under the history of present illness. They are the location, quality, severity, duration, context, timing, modifying factors, and associated signs and symptoms. The HPI may be accumulated from elements of different problems, or all of the HPI may come from just one problem. For instance, credit may be given under modifying factors for the patient's compliant use of insulin with their diabetes, while associated signs and symptoms is credited for the edema due to the patient's hypertension. HPI is very subjective because people's minds perceive information differently. As long as it makes sense to credit an element for the documentation, there really isn't a right or wrong way to do it. However, if information is credited in one area of history, it cannot be used to fulfill another element or area of history. This table lists the 8 elements of HPI, and essentially providers are answering a question about the patient's problem when they obtain HPI. I have listed some examples of documentation that may qualify for each element. However, these are by no means an all-inclusive list. The location identifies where the problem is occurring. The duration tells us how long that patient has had that problem or when it started. Quality is an adjective describing the patient's signs or symptoms. Severity describes how severe the problem is. Context will tell us where the patient was or what they were doing at the onset of the problem. Modifying factors identifies what the patient is doing to make the problem worse or better. Timing will tell us when the problem occurs, and associated signs and symptoms describe any other problems that are present related to the chief complaint. The provider should obtain and document the information they feel is pertinent to the patient's condition. There are 2 levels of HPI. A brief HPI would have 1 to 3 of the 8 elements documented in the note, and the extended HPI allows 2 options. The provider can document 4 or more of the 8 elements we just reviewed, or they can document the status of 3 chronic illnesses. When documenting the status of 3 chronic illnesses, I recommend documenting more than the status alone, as this may not clearly describe the problem. For instance, if the problem is uncontrolled, we don't know the extent to which the problem is uncontrolled. Vague documentation leaves a great deal of room for subjectivity when the note is reviewed by someone else. Generally, providers document the HPI in paragraph form. In this example, we see the chief complaint documented as well, with the statement that the patient is coming in for follow-up of their hyperlipidemia, hypertension, and diabetes. The patient is on metformin and compliant with her medication. She states she has some numbness when she is sedentary for too long. She checks her blood pressure regularly at home and is compliant with her hypertension medication, but is continuing to have pitting edema. She also has been having some severe leg cramps, which she rates as 6 to 7 out of 10, and they occur intermittently at night. The cramps started when she went on a statin 6 months ago, and she recently stopped taking her statin due to the intensity of the leg cramps. In this example, we actually were able to obtain all 8 of the HPI elements, and I have listed the HPI element in blue right behind the terminology that would support that element. This grid is from the history section of the auditing tool provided by WSPA. We want to mark off each element in our HPI example. Numbness is given as an associated sign and symptom. The numbness is most prominent when she is sedentary, which is context. The cramps started 6 months ago, which is the duration. The cramps occur in her legs, which is location. Medications and taking them compliantly, except for the statin, gives us modifying factors. Pitting describes her edema, so that could be credited to quality. She rates her leg cramps as 6 to 7 out of 10 on the pain scale, and that is credited as severity. And the cramps occur intermittently at night, which gives us timing. With this example, we qualify for an extended HPI because all we needed was 4, but we actually had all 8. By documenting the patient's account of her problems thoroughly, the provider was able to obtain an extended HPI. Coders and auditors will stop counting at 4 HPI elements since that is all that is required for the highest level of HPI. And if there is documentation that may be used for another element of history, such as the review of systems, that documentation will be credited to that element of history instead. The review of systems is the patient's account of any signs or symptoms that they are having or have been experiencing. And this information is usually the result of the provider asking the patient questions and documenting their responses to each question. Many times providers intermingle the ROS responses in with the HPI, which is acceptable. Documentation cannot be double-dipped and counted for more than one element of history. In the example we had for our HPI, numbness was credited under the associated signs and symptoms in the HPI, so we cannot also count that same documentation to the neurologic system in the ROS. The provider should decide which systems to inquire about, but it should be medically necessary to question a patient about a system. The systems reviewed should be related to the conditions being assessed during the encounter and should be a live accounting of the patient's responses. The ROS helps define the problem and also helps the provider know which tests may be needed to be ordered. It gives a baseline on other systems, and it can help clarify differential diagnoses. Providers are required to document the positive and pertinent negative responses, and if all other systems are reviewed and are negative, CMS states that the provider can use a statement that all other systems were reviewed and are negative versus listing each system individually. If the provider is using a paper chart and referring to a previous health history form or review of systems, the provider must sign and date the previous note or health history form that is being referred to each time to provide an audit trail of their review. In an electronic health record, there is usually some type of Mark as Reviewed button that the provider can click, which leaves the same audit trail. If the information reviewed is specifically pulled into the note, that is sufficient. The next 2 slides are a list of the systems and some examples of signs or symptoms that would be classified to that system. This is not an all-inclusive list, but should give you some idea of which systems would be credited for information in your documentation. Some symptoms can be classified to different systems. For instance, weight loss is generally credited under constitutional. However, if the patient has an endocrine problem and has had rapid weight gain or loss, that may be more appropriately credited to the endocrine system. The allergic and immunological systems are sometimes reviewed as being past medical history and not truly a review of systems. For example, if the patient doesn't have any allergies, should that really count as a review of systems, or should it be past history? I try to view this logically. If the provider documents that there are no known drug allergies, then I will usually credit that documentation to past history versus the allergic system. However, if the patient does have allergies, then I would say it is more appropriately identified as a system review because those allergies may very well play a role in the provider's treatment plan. For instance, if a patient has an allergy to shellfish, that may be a deciding factor in which drug the patient is given, as some medications do contain shellfish. CMS states that allergies can be counted as either past medical history or as an ROS, but not to both for the same encounter. There are 3 levels in the review of systems. A pertinent ROS is review of one system that is directly related to the presenting problem. An extended ROS will document 2 to 9 systems and include the systems directly related to the problem and additional systems necessary in the provider's opinion. A complete or comprehensive review of systems requires that at least 10 systems be reviewed. Best practice is to individually list all systems reviewed and the patient's responses if you are not reviewing all of the systems. This is the next section of the WSPA auditing tool under History. Let's see what level of ROS we have in this example. Again, I have listed the system the terminology would be credited to in blue. No weight changes would count toward constitutional. No chest pain was credited to cardiovascular. No shortness of breath to the respiratory system. No abnormal bleeding or bruising to hematologic. No excessive thirst to endocrine. So we have an extended ROS because we have documented responses in 5 systems, and that falls between the 2 to 9 systems required for an extended ROS. Past medical, family, and social history is pretty self-explanatory. The provider should obtain and document the history information they feel is relevant to the encounter. Past medical history is information about the patient's prior illnesses, injuries, diagnostic testing, and treatments. Current or past medications would count as past history. Family history records medical events, diseases, and hereditary conditions that may place the patient at risk. Social history is an age-appropriate review of the patient's past and current activities and includes information about marital status, employment, education, drug, alcohol, and tobacco use. Negative responses may also be credited for history. For instance, if the patient states they have never smoked, that can be credited to social history. This grid provides examples of information that may be counted toward each history, but again is not all-inclusive. One specific finding within each history will credit the provider for that type of a history. There are 2 levels of PFISH, pertinent and complete. A pertinent PFISH would be one specific item from any of the 3 histories which is directly related to the problems recorded in the HPI. The most common history documented by providers is the past medical history because the patient's medications are generally always included in the progress note and contribute to the provider's thought process regarding treatments in most cases. The complete PFISH requirements vary depending on what type of encounter is being performed. A complete PFISH for new patient visits, initial care in a facility, and consultation codes require one specific item from each of the 3 histories. These are services that by their nature should include a comprehensive assessment of the patient's history. A complete PFISH for established patient visits and subsequent facility care require one specific item from 2 histories to qualify for a complete PFISH. In our PFISH example, the provider has documented the patient's current medications as simvastatin, metformin, and furosemide. They told us that the patient is married and has never smoked, and that there is a strong history of hyperlipidemia and cardiovascular disease in the patient's father's family. This is the next section of history from the WSPA auditing tool. Past medical history is credited for treatments since we know what the patient is currently taking for medication. Social history is credited for the patient being married and not a smoker. And family history is credited for the history of cholesterol and cardiovascular disease on the father's side. So we have at least one specific item documented within each of the 3 histories, and our level of PFISH assigned to this example is complete. The chief complaint, review of systems, and past medical family social history may be listed separately or included in the HPI. CMS states that the review of systems and the past medical family social history previously obtained does not need to be re-recorded if there is proof the provider reviewed and updated the information. In an electronic health record, there is usually a review button that the provider can click to indicate that they reviewed each section of history. This leaves an audit trail that may be referenced if needed. Providers should always describe any new review of systems and/or past medical family social history, or notate that there has been no change. If notating no change from a previous ROS or PFISH, the provider should reference the date and location of the note that contains the information that was reviewed. For instance, documentation might state past medical family social histories and ROS were reviewed from the July 15th visit and remain unchanged. CMS states that ancillary staff may obtain and document the ROS and PFISH, but the provider must review information recorded by others and supplement or confirm what they recorded. If history is unobtainable for some reason, providers should document the history that is able to be obtained, whether it's from medical records, family members, or other caregivers, and state why the rest of the history cannot be obtained. And an example of when this might be necessary is when a patient suffers from dementia and they cannot recall all of their history. So let's dissect this case study to determine what levels of HPI, ROS, and PFISH are supported, and then we will calculate the overall level of history based on our findings in each of these elements. Please feel free to have a blank copy of the WSPA auditing tool out and work through this with me. Our patient presents for medication management of diabetes, hypertension, and cholesterol. The patient has had hypertension since 2012 and has a home blood pressure monitor and is not taking their medication, which was last filled in 2014. They have intermittent edema, which was severe when traveling to Europe. Diabetes, the patient is negative for hypoglycemia or polyuria, but does have polydipsia that wakes her at night. Her medication adherence is intermittent. There are no side effects reported, but she struggles to take it sometimes. She is not checking her blood glucose, but is trying to eat healthier. There is a diabetic complication of nephropathy. She has been taking her simvastatin, which also has not been filled since 2014. Her sleep is poor and she takes trazodone to help with that. She also has CKD, but no issues are noted. She is drinking water and eating a high iron diet for her anemia. She feels fatigued. She gets dysphagia when taking pills and coughs with foods and liquids infrequently. She reports depression since the recent death of her dog, and she is taking citalopram, but not sure if it is helping. She uses lidocaine patches for her shoulder pain and struggles with constipation, which is improved by eating a prune every day. Before we get started on each level of history, let's look at the directions in the history section of the auditing tool. It tells us to determine the level of HPI, ROS, and PFISH, which we will do in a minute. Number 2 states to circle the entry furthest to the right of the table that best describes the HPI, ROS, and PFISH. If a column contains 3 or more circles, we draw a line to the bottom of the column, and that determines our history. However, if no columns contain 3 circles, the column containing the circle farthest to the left identifies the type of history. So let's get started. We know we have met the requirement of a chief complaint, as the note clearly stated that the patient was there for medication management of diabetes, hypertension, and cholesterol. Context is credited for when traveling, because that is what the patient was doing at the onset of her severe edema. Duration is credited for 2012, as that is when the patient was diagnosed with hypertension. Modifying factors is credited for the patient not taking medication prescribed to them or checking their blood pressure. Severity is credited for documentation of severe, which describes the edema. And timing is credited because the edema is intermittent, which tells us when the problem is occurring. This gives us a total of 5 HPI elements, and we have met the criteria for an extended HPI and would circle that option in the column furthest to the right. The review of systems in our case study is extended. Cardiovascular is credited for the edema, as the edema was not used as an associated sign and symptom in HPI, so it can be counted toward the ROS. Constitutional is credited for the patient's fatigue, endocrine for no hypoglycemia, positive for polydipsia. GI is credited for constipation and dysphagia. GU for the no polyuria. Hematologic for the anemia and eating a high iron diet. Musculoskeletal for the shoulder pain. Neurologic for the poor sleep. Psychiatric for the depressed mood. So we have a total of 9 systems that were reviewed. In our case study, the past history is documented because the current medications and medications that she had taken in the past are documented. Since we only have one history obtained, our level of PFISH is pertinent. When you follow the direction on the auditing tool, the line drawn should lead you to detailed, and this would be the level of history assigned to our case study. I couldn't fit all 3 of these sections onto one slide for you, so I put a condensed version of each section onto a table that represents what the total history section should look like. So as you can see, we have 1 in the 4th column that is circled, and 2 other sections that are circles are in the 3rd column, and therefore our level of history would lead us to the detailed history. In an outpatient or office setting, a detailed history would support 99203 for a new patient and 99214 for an established patient. Keep in mind that the other key components will need to be met as well, but our history would support these levels of E&M. In a domiciliary or assisted living center, a detailed history would support 99326 for a new patient and 99336 for an established patient. In a home setting, a detailed history supports 99343 for new patients and 99349 for established patients. In an inpatient hospital setting, a detailed history would only allow us to obtain the lowest level of initial care, which is 99221. For a subsequent visit, a detailed history would support the highest level, which is 99233. In a nursing facility, a detailed history supports CPT 99304 for initial care and 99309 for a subsequent visit. If a consultation is being performed, a detailed history would qualify us for the 3rd level in either the outpatient or inpatient setting. Our codes are 99243 for outpatient and 99253 for inpatient. Here are my sources for this session. I encourage you to read them for yourselves for a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding E&M coding. Thank you for listening to our session on history. I hope that it has helped you to understand how the clinical information you document is used to support history levels as defined by CMS and CPT for the E&M codes.